So this is our final section for Chapter 12, muscle relaxants. So muscle relaxants act to relieve pain associated with skeletal muscle spasms. The majority of these are centrally acting, with the CNS being the site of the action. Now, they're very similar in structure and action to our other CNS depressants. They act directly on skeletal muscle and closely resemble GABA. Skeletal muscle spasticity, or these spasms that the patient's having, is often a result of a neuronal problem, not a muscle deficit. And so the reflex arc involved in coordinating skeletal muscle action involves several neurons, including interneurons and those in the spinal cord. These spinal polysynaptic reflex arcs are depressed by a number of drugs, and that includes our barbiturates, as we talked about before, and our benzodiazepines. Remember that the benzodiazepines allosterically facilitate that GABA-mediated chloride influx, and so that works throughout the CNS, including the spinal cord. So when we use other GABA medications, like baclofen, this is one of our muscle relaxants we're going to talk about in a minute. It's a GABA 8 receptor agonist, and so it hyperpolarizes the neurons, and what it does is it increases the potassium conductance. So other of the medications may work on an alpha-2 adrenoreceptor agonist and the GABA, or our GABA-A receptor agonist, but what they do is they clearly inhibit the excitability of this neuron and decreasing then the muscle spasm or the stimulation of the muscle. And that's why they're indicated for the relief of painful musculoskeletal conditions like the spasms. We also will see spasticity in severe chronic disorders like multiple sclerosis or cerebral palsy. And when you think about it, physiologically, that makes sense. The spasticity occurs because of this neuronal problem. Obviously, muscle relaxants work best when we use them alongside physical therapy. The most frequent diagnosis that you're going to see for the use of muscle relaxants is, can you guess? Low back pain. I know that's what you were thinking. Low back pain. You'll see it abbreviated on the charts as LBP. It's the #1 diagnosis across the country. Low back pain. So when these muscle relaxants have adverse effects, we're going to see an extension of the effects on the central nervous system and the skeletal muscles. So you'll see euphoria, maybe lightheadedness, dizziness, drowsiness, fatigue, muscle weakness, and other effects that are going to result from this CNS depression. Our common muscle relaxants, baclofen, cyclobenzaprine. Cyclobenzaprine, Flexeril, not being prescribed as much as it used to be because it does have a significant ability for, or susceptibility for abuse. Dantrolene, don't see very much. Metaxalone, don't see very much, although we do still see that. Tizanidine is a very popular and the newest, I would say, of these drugs. We'll talk about that in just a second. Carisoprodol, that's our soma, not being seen used very much at all. In fact, it's pretty much an obsolete drug. Chlorzoxazone, that's Paraflex, don't see it used as much. Methocarbamol, that's Robaxin, we'll see that. So our more frequent ones you're going to see are baclofen, tizanidine, and methocarbamol. Metaxalone is by most insurance companies considered a second step. So if you fail the Robaxin, the baclofen, or the tizanidine, then they'll let you have the metaxalone. With tizanidine, the great thing about tizanidine is it comes in a 2 milligram, 4 milligram, or 6 milligram, but they come in a quartered scoreability tablet. So you can actually take a tablet and cut it into 4 parts equally because it's scored and adjust dosages that way. So that's one of the new things, or the great things about tizanidine. Tizanidine's a little bit different from the others in that it is an agonist at the alpha-2 adrenergic receptor sites, and that's how it works. It has a stronger action on the polysynaptic reflexes, which involve several of those interneurons, those relay neurons, and they then decrease the stimulation of the muscle movement. So let's talk about the nursing implications of our CNS depressants and our muscle relaxants. Before beginning therapy, we want to obtain a very thorough history regarding allergies, use of other medications, health history, medical history. Make sure that we've got baseline vital signs and intake and output, including supine and erect BP. So we want to do the 3-step, what do we call them? Orthostatic blood pressures. So let's make sure that we get those. We want to assess for potential disorders or conditions that may be contraindications and for potential drug interactions. We want to give hypnotics 30 to 60 minutes before bedtime for maximum effectiveness in inducing sleep. And that depends on the drug's onset, but the majority of them are going to say 30 minutes before bedtime. Most of our benzodiazepines cause REM rebound and a tired feeling the next day. We want to be sure that those are used very cautiously in the elderly. Instruct our patients to avoid alcohol and other CNS depressants with any of these drugs that we've discussed today. Check with the prescriber before taking any other medications, and that includes over-the-counter medications. For example, we wouldn't want to take our benzodiazepines with kava, right, or valerian. Rebound insomnia can occur for a few nights after we have a 3 to 4 week regimen that has been discontinued. So we want to let the patient know that they can expect that. If we're giving these medications in the environment, at the clinical environment, we want to remember safety. We want to teach our patients about safety. If it's allowed in your facility, use your side rails, keep your side rails up, or perhaps consider a bed alarm. Don't permit smoking. Patients with these medications on boards can burn themselves. Assist your patient with ambulation, especially the elderly, and then help to keep the call light within reach for them. Monitor your patient for adverse effects and teach them what to monitor for if they're taking these medications in the outpatient setting. We also monitor for the therapeutic effects. Are they actually having an increased ability to sleep at night? Are they awakening fewer times? Is there a shorter sleep induction time? Are they having few adverse effects, such as the hangover effect? Overall, improved sense of well-being because of the improved sleep. Is that happening? For the muscle relaxants, are we actually decreasing the spasticity and decreasing the rigidity? Important things for us to think about as we teach our patients about central nervous system depressants and skeletal muscle relaxers. So remember, you know how to get a hold of me: email, text, call, or post in the discussion forum. Look forward to seeing you soon.